It's true though. Yeah, in fact, and off Central Vermont. Right, and so was UVM.
The country's looking into it now.
Okay.
Applications done. Yeah. Community work
Sorry,
system.
I really had a rough time with it.
Good morning. Michelle, are you here?
Yes, I am here. Can you see me?
No, but I can hear you.
No. Oh, okay. I thought I turned my camera on. There I go. It's a
Ah.
little delayed. Microsoft Teams is giving me a hard time today.
Gives me a hard time every day. And the Mount Ascutney team, I see you. Do you have everyone you need?
Yes, we do.
Great.
Can Mr. Chair, just so that I know who's speaking on that conference room, just have them tell me who they are, so I know. I
Yeah.
can write. I can note who's who.
So before we get on the record, before we start, just for the Mount Ascutney folks, can you introduce yourselves? And then when we go on the record, we'll have our attorney swear you in, and you can each identify yourselves and say whether you attest to the oath. But for now, could you just introduce yourselves to Michelle?
I'll start here. Hi, I'm Dr. Herbert Ip. I'm the interim chief medical officer here at Ascutney Hospital.
Okay.
Wynn Brown, interim CEO.
Brown.
Celeste Pitts, interim CFO.
I am Andrew Jeremy. I'm the director of finance.
Okay, got it. Thank you for that.
And we have a slide coming up, so you'll be able to get the names spelling from that slide.
All right, great. Michelle, we can go on the record.
Okay, we are now on the record. The time is 9:11 a.m.
Good morning. I'll call to order the Green Mountain Care Board's hearing of August 14th. We have 3 hospital budget presentations today. We'll start with Mount Ascutney. Mr. Brown, I'll have our attorney Mark Hengsler swear you all in, and then he'll turn it to you and you can take away the presentation.
Hey, good morning, Madam Ascutney. Good to see you. I'm going to administer the oath for witnesses. What I'll have you do, I'll read it, and I'll just have you go down the line, raise your right hand, state your name, and state I do if you agree to the oath. So I'll just go ahead and read it, and we can go from there. Do you solemnly swear that the evidence you shall give relative to the cause now under consideration shall be the whole truth and nothing but the truth, so help you God?
I do.
Dr. Herbert.
Dr. Herbert Ip, I do.
Wynn Brown, I do.
Celeste Pitts, I do.
Andrew Jeremy, I do.
Thank you. You're sworn in now, and I'll turn it to Mount Ascutney to present to the board.
Well, good morning, everyone. Thank you for having us here this morning. We appreciate it. Andrew's going to bring up our presentation. I don't know what number we are for you, but you've seen a number of these, and we'll do our best to work through the slides efficiently and save time at the end for questions that you might have. Let him get himself situated. Just have to share the right screen, sorry. Next slide. Just to introduce ourselves one more time in case it didn't come through clearly, I'm Wynn Brown, interim CEO here. This is actually my second Green Mountain Care Board presentation, so I've been here a little over a year, leading Mount Ascutney. Dr. Ip, to my right, is our Chief Medical Officer and also leads quality for our organization. Celeste Pitts is our interim Chief Financial Officer. She's also the interim Chief Financial Officer for Valley Regional Hospital across the river in Claremont. We're going to talk a little bit about that. coming up in our presentation, which is important to the future of both our hospitals. And Andrew Garamy is a face I know that's known to many of you. He's been in many of these hearings before and helps in their financial piece. For our agenda today, we're just going to give you a brief overview of who we are. We're going to talk a lot about quality and access, cost, what our request is, and then talk about our risks and opportunities as we look to our budget for the coming year. So we look forward to getting into that with you. So just to perhaps refresh everybody's understanding of who we are, Mount Ascutney. This is our main campus in Windsor. We serve southern Windsor County in Vermont, and also a fair number of our patients come from across the river in New Hampshire. We are less than a mile from the river, and so we are very close by, and I don't know if we'll get into it today or not, but I think you're aware of some of the challenges of border hospitals like ourselves in southwestern Vermont when you're very close to other states and how that affects your payer mix and your services as well. So we're 25 beds for critical access, so acute and swing beds. We also have a 10-bed distinct unit, one of a handful of distinct 10-bed units in the country for inpatient rehab. We're one of 2 inpatient acute rehab facilities in the state, and the only one that is CARF certified, which is a very extensive certification that we go through to ensure the quality and service, and we'll talk a little bit about that later in our presentation. We also have Ottauquechee Health Center in Windsor, which is a primary care practice and behavioral health practice. We have an ophthalmology practice in Hanover, New Hampshire. We're going to talk about ophthalmology later. And on this campus, we have a rather large primary and specialty care practice right here embedded in the hospital. As you may be aware, we're well recognized for our quality, and Dr. Ip will share some of our recent recognition that we have, and our service levels. When you look at our Press-Gini patient satisfaction, and as well as our staff engagement, we're among some of the highest in the country. Our mission is to improve the lives of those we serve, and we do that really with a robust array of services that we feel are appropriate for our region. We do not try to be all things to all people. We are not large enough to have every single specialty, but luckily in partnership with Dartmouth Health, we have the ability to bring some of their specialists on our campus part-time to make sure that patients get their care locally. And we're 30 minutes south of Dartmouth Medical Center's primary campus. So we have relatively close access to that as well. So that's helpful to our population. I just wanted to share with you the org chart for Dartmouth Health, because there is the recent change of Valley Regional Hospital coming in to become a full member of Dartmouth Health a couple of weeks ago. And what does that mean for us? Well, that means that we've always had a close collaboration with Valley Regional Hospital. We share a number of staff between our organizations because as a critical access hospital and given our size, you know, we need a lab director, but we don't need a full FTE of a lab director. So we share our lab director between the 2 hospitals. We share respiratory services manager between the 2 hospitals, our 340B specialist we share, as well as emergency preparedness. And we see that there's a number of opportunities in the future now that Valley has come into the system to share even more. One of the things that is underway right now is a search for a CEO to serve both hospitals. Following that will be a search for a chief financial officer for both hospitals. So if you think going forward, the expense of some of those overhead people like myself will be shared and lower the cost of operating both the hospitals. We haven't gotten deep into what are those next steps because, as you know, you're competitors until you are not. And now we are members of the same family. We're going to begin some of those conversations of where we can collaborate better. So and Celeste is going to touch on that a little bit later in the presentation. The other piece that we have that is we also own Historic Homes of Runnymede, which is a 39-bed assisted living campus in downtown Windsor, which has been a subsidiary of ours for a long time that we inherited from a local not-for-profit. But we have worked very hard this year to bring it in closer to us, to share our HR platform, to employ everybody off, and you'll see that in the financials that Andrew will see, to make sure that we maintain access for long-term care As you know, access to long-term care in the state of Vermont is very difficult. And so we feel very firmly that we need to make sure that that organization, which serves a large number of Medicaid patients, our residents in our region, that they have access for that. So we can talk about that more later if you would like. I will also say with Valley Regional Hospital coming in that our boards have mirrored. So the board as of last week, the trustees of Mount Ascutney Hospital are the same trustees for Valley Regional Hospital. So we will have mirror board meetings. And so those two boards can make decisions for the greater region as to which services should reside where. A perfect example for us historically has been, we do not provide orthopedic surgery on this campus. Now, a lot of hospitals pursue orthopedic surgery because it's profitable, but we haven't done that for a number of years because Valley provides it across the river. So now that we're together, we would not look to compete on certain service lines when it really only needs to be specialized on a particular campus. Next slide. I'm going to turn it over to Dr. If, who's going to talk a little bit about our quality recognition and our quality programs for which we're widely recognized.
Great, thank you. Here at Mount Ascutney, we take a lot of pride in our work and quality, and as part of that work, we assess our patient experience scores. We use Ascutney to measure those scores. We highly value the patient experience here as it helps drive quality, patient safety, and outcomes. And we've been high performers across various domains and patient experiences as seen here. Our healthcare providers perform well above the national average and Vermont average in multiple domains, including provider communication, medication communication, patient education, and that's all reflected in this slide here. Next slide, please. And as recognition for our quality, in 2023, we received the Guardians of Excellence Award from Ascutney, and that's awarded for us scoring a 95th percentile for patient experience. And this was the second year in a row that we've been awarded this. We were also awarded by Chartis in 2023 the Performance Leadership Award. That recognizes our performance among rural hospitals in quality, outcomes, and patient experience. Also in 2023, we were accredited for level 2 geriatric ED. We're one of 2 hospitals in Vermont who have achieved that level 2 accreditation in Vermont. And that really demonstrates our commitment to integrating geriatric healthcare delivery into our daily operations. In 2024, we received our 3-year reaccreditation for CARF, and that's for our acute rehab facility. And this accreditation has a particular focus on stroke. But that's a very arduous recertification, and we're very proud of that. One of the probably few critical access hospitals in the nation that are CARF certified. So next slide, please. Here we have a strong culture of quality and safety throughout the organization. I think a lot of that has to do with getting our staff engaged and committed in quality. Also, as part of the Dartmouth Health System, we participate in the Patient Safety Organization, and that helps standardize a lot of quality workflows and norms across the health system for all the member sites. We've, as part of some of our improvement initiatives, we've implemented controlled substance best practices here and across the system. There's ongoing work on things like mortality reduction, hospital readmissions. We partner with other hospitals in these initiatives. So, that's part of the work that's ongoing moving forward. Next slide, please. So rehab is a big part of what we do here at Mount Ascutney, and we're one of 2 acute rehabilitation facilities here in Vermont. And so as I spoke about earlier, we accredited our 3-year certification for CARF for our inpatient acute rehab unit. But for the very first time as well, we received a 3-year accreditation for our outpatient therapies program. And this reflects a lot of a testament to the hard work of our nurses, physical therapists, occupational therapists, caseworkers, our providers, of really performing to the top of their abilities. And you can see that our CMS satisfaction scores really reflect that hard work. Next slide, please. Also in 2023, we completed a very successful CMS recertification survey where there was only one item that we were asked to address. And it was just a verbiage change in one of our policies. There was no other concerns cited on the survey, so we were very proud of that. Part of our success is really the approach that we take here in our organization. We focus on being ready for the next patient, for the next survey. Our team takes a lot of pride in this work, making sure that we remain vigilant, performing mock surveys throughout the year to stay prepared, doing a lot of detailed work in quality metrics. So that's just a lot of preparation work. Next slide. And our quality measures are strong across the board, whether it's radiology, laboratory, and the clinical practices. As part of the Dartmouth Health System, we perform well within the system for our quality metrics, often ranking second in the system and above the 75th percentile in a lot of our metrics. As part of maintaining this strong and consistent performance and quality and in our surveys, this requires an investment in the team, and that's management and data analytics and doing mock audits. And this in turn feeds into high employee engagement, retention, and patient satisfaction. Slide, please. Turn this back over to Wynn about access.
So access is an issue across Vermont and across really the DH system, ensuring, especially around primary care access, is particularly on this campus. So this is just an example of the array of services that we provide, and they're in different colors. So you can see which services come from Dartmouth Health, which are jointly with us in Dartmouth Health, and who we employ on our own. So cardiology, gastroenterology, general surgery, neurology, oncology, ophthalmology, which we're going to talk a bit about, which is very important to us and I think to the state of Vermont as we dramatically grow that program and a long-term specialty of ours. So you can see the array of things that we offer. We're not, as I said, all things to all people, but we have a relatively comprehensive array. Part of the challenge of any critical access hospital is that a lot of these benches are not very deep. So, we may only have one or half-time or part-time or provider in this area. And if we lose one, lose that provider to moving out of the region, it does create a challenge for us. But luckily, we've been able to partner in some of these instances with Dartmouth to help fill those holes through our arrangement of leasing a provider to come to us. Next slide. This is one of the big challenges that we face right now. This is our visit lag. So from getting an appointment, how long it takes to get an appointment. And you can see that over the past few years that it has gotten harder to get in on a timely basis for us. There have been the challenges really largely around primary care. We have lost a number of providers, or we have providers that are aging and working less hours. But still practicing. And so we've been working very hard on recruiting those providers as well. Dartmouth actually has set a goal that any patient can get an appointment in any specialty within 14 days. And so that is our target as well. We are right now, I think we sit at 44 days to get into an appointment on average. But it's a huge challenge, especially in a rural area. We sit on the border of New Hampshire, which also makes it a challenge to recruit and retain people, especially when they can work just across the river and not pay income tax. We run into that actually a great deal. And so they choose not to come practice and be employed by us. Next slide. So we are doing a lot of things around that. We are obviously regularly monitoring the productivity of our providers, and we share that information with them. We're very focused on our wait times. We are not open right now to new primary care patients. We have a wait list to come in. We expect that wait list to open in September, as we have a couple of new nurse practitioners coming on board shortly. We've also, you saw in Dr. Hammery's presentation, looking at the scheduling of appointments and the duration of those. And we've been making adjustments with our providers to open up their schedule with some shorter appointment times to make sure that we can try to get patients in on a timely basis. We've also expanded our walk-in clinic hours to help catch some of those patients that need to be seen on an urgent basis, but don't need to go to the ER. And that has been very well received by the community. So we are working hard. Our staffing levels in our practices overall right now are good when it comes to nurses and support staff. But we are challenged by, as you've heard in every presentation, the salary requirements now to successfully recruit and retain people across the whole health system at every level. And then really working hard on our hours and schedules to make sure that we open up the access as best we can. Next slide, Andrew. This is from Dr. Hammery's presentation about what are across the state, the high impact actions that organizations can take. And you can see that we essentially have implemented or have been implementing all the things that he has recommended that we look at as a state. I will say one of the things that we've been working really well with, and it's been maturing very well at Dartmouth, is the transfer center. So we now move patients between the Dartmouth affiliates much more efficiently and effectively than we used to. So patients that are at Dartmouth Hitchcock in LEB who no longer need that level of care but still need acute care or swing care, we are in regular communication to see who can move here. And likewise, if we have someone that is beyond the care abilities of our organization, how do we get them to DH or to UVM for that level of care so that we keep them in the region? And so that has come a long way, and more things are happening there. So that is a good thing. That also allows Vermont residents to come back into the state of Vermont to be cared for at a lower cost facility and oftentimes closer to their loved ones and their support system. So we see great progress there, and we're very excited about that in particular. And it's been a great partnership. It's taken a couple of years to get there. One of our big challenges, and we'll talk about it when we get to our capital request, is that we are on Cerner for our electronic medical record, where the Dartmouth system is on Epic. And so that creates a lot of friction in moving information back and forth as we try to move patients efficiently to the appropriate site of care. So we'll talk about that a little bit later. We also, to lower our costs as well, buy a lot of services from Dartmouth for our back office. So our human resources, for our benefits, for a number of the finance things that we do, so that we don't have to try to recruit and retain those people locally. We can buy the piece of service that we need through a PSA with Dartmouth. And so we're doing more and more of that, which alleviates the stresses on a small hospital like ourselves. Next slide. I'm going to turn it over to Andrew.
Yes, I get the privilege of talking about cost, everybody's favorite part of healthcare. On the screen are services that relate to cost management that we do at here at MAHHC and with the system at large. These are consistent with prior year submissions and things that we do on a daily, weekly, monthly, and annual basis. And they result in some significant cost savings when compared to doing the work on our own. Wynn mentioned a few PSAs, some shared service, finance. So for finance, we have access to beneficial loan terms and rates. By being a part of the Dartmouth Health Obligation Group, we have access to alternative investment strategies and plans through the Dartmouth Master Investment Program. We're part of NIA, the GPO, Group Purchasing Organization, that gives us access to beneficial pricing. And we get even more benefit by being a Dartmouth affiliate. There's several levels and tiers of benefits. For pharmacy, we have access to 340B programs and initiatives that combat manufacturer restrictions, and I'll share a little bit more about that later. And you touched on it, shared services is a really big benefit for us. Being part of the system, we get a lot of savings there. For example, this year, so shared savings are allocated on a proportional basis among the system for system-wide activities that we all benefit from. And quality is a big one. And we received an $800,000 credit just for quality because we spent $800,000 more proportionally to our affiliate members, and in large part because of Cerner. We have to do the same quality and compliance work that everybody else has to do, but we have to do it all on our own, on our Cerner Island. So as a critical access hospital, by our nature, we're a high fixed cost organization. Medicare recognizes us as a critical community resource, providing care to a geographically and demographically disadvantaged region. It's a highly valuable designation. It means a lot to us in the community. And it also means that, by nature, we provide community-based care. I wish we did ortho. I wish we did plastics, but we don't. We do primary care and we do podiatry and the things that our community really does need. But we still have to maintain the same conditions of participation as partner hospitals. We have to keep our ED staffed and the lab and the rad staffed. We have to maintain minimum staffing volumes. We have to submit the same budgets that UVM does. But here at Mount Ascutney, we have a culture of financial transparency and cost management. We develop and distribute monthly P&Ls to all of our department managers and to leadership and the board at large. And we work with our management team to kind of train them on how to read those financial statements, what they mean, and how to turn them into action. We value financial transparency. Our managers can see every invoice and every charge from their providers. We distribute biweekly payroll reports with FTEs against budget and travelers and overtime. Everything, we try and give our management the tools they need to manage their departments effectively. We have position control, which I've heard some other hospitals have as well. Every FTE, new FTE, whether it's a net new position or a rehire or replacement, has to go through position control. The manager has to apply for that posting. How annoying it is.
And it goes to the senior team for approval.
Yes, it's all made of senior leadership. We leverage the NIA GPO as much as we can, but we're not obligated to use them. So we're able to kind of use our own resources to find good deals as well. And Martha Colburn, our purchasing manager, is a rock star and is able to really navigate that world really well. And for the costs that we do realize, the expenses that we see every day, managing the cost report effectively has a significant impact on our bottom line and on our costs. One of my goals every year is to pay for myself through a cost report, plan or study or initiative. And this year I worked with Belinda Shropshire, our Senior Director of Rehab and Ancillary Services, and we identified some employees were they were assigned to a non-reimbursable cost center, the rehab department, that's paid on DRG, so not cost-based. But we realized that they were doing, half of their work was for rehab and half of it was for acute. They were doing referral services. And so we created a new department, allocated or assigned those employees there, and then allocated their costs by admission statistics. And we were able to pick up $200,000 this year in perpetuity because of that cost report optimization. And then, of course, more DH system integration efforts for FY25, which I'll talk about now. As Wynn mentioned, we not moving the slide. Yeah. When mentioned, we transitioned our benefit platform this year to DHs, and we saved 250 grand this year by doing that, by reduced management and overhead. And we passed that along to our employees so they would experience a lower premium increase. We're proud to do that, and we expect to continue to realize the benefits of being part of this platform by being a part of a larger risk pool. So we're seeing a lower premium increase than we would have expected otherwise. As a side note, our doesn't really sound this right if you look at our P&L, because our benefits are going up significantly, and that's largely because we've adopted our HHR employees onto Mount Ascutney's books, so that they could have access to those benefits and pay scales that we have at Ascutney. It's the right thing to do for them and for us and for the community, but the expenses will go up because of that. But there's an offsetting increase in other operating revenue. And of course, we have our phase one, the enterprise resource planning integration of our CON, which is expected to deliver some pretty good administrative synergies. I won't have to manage payroll anymore, and I won't have to do AP, and I won't have to do bank recs. I'm very excited. And that cost will go to DH, and DH will share it proportionally. So on average, costs will go down. We have to do a little investment to get there, but very excited about that. Eagerly awaiting your response. And we'll have access to best-in-class accounting, analytics, and HR tools. We'll be able to deliver on some of the items that we weren't able to deliver on this year, like segregating Medicare Advantage and including that part of future budget submissions. And then phase two is the electronic health record piece, Epic integration, and we hope and anticipate to see the same kind of synergies on the clinical side. For FY25 budget, the 340B alternative distribution model is a program that Dartmouth is sponsoring and has developed to combat manufacturer restrictions in 340B eligibility. They've essentially designated a warehouse, a central distribution warehouse, as a primary pharmacy. They get all their drug orders there, and then they redistribute it to a network of contract pharmacies. So really ingenious and great strategy to help claw back some of this 340B revenue. We're going to probably see 120K at least this year. So that's going to go live January 1st. And shared services, talked about it already, but as Valley Regional comes online, as SVMC becomes more integrated, we're going to continue to see the benefits of shared services. And Celeste will actually explain a little bit more of the benefits about that.
Thank you, Andrew. So first of all, very happy to say, as Wynn mentioned, that Valley is now officially a part of Dartmouth Health, effective August 1st. So it's been a long time coming. Very happy now we have the opportunity to start working together. And so this analysis that you're looking at was something that Dave Sandville had put together a few years ago to outline mainly to Valley why they should join Dartmouth Health and why they should partner with Mount Ascutney. So the supply chain, insurance, and PSA reductions that you can see that Valley will eventually pick up, they've already been realized by Mount Ascutney and have been part of our budget for a while. Andrew's alluded to them, Wynn's talked about them. Management and staff, we say reductions, but really what they are is opportunities to share. So Wynn mentioned a lab manager and a pulmonary manager, 340B resource, and a emergency services. We currently share those positions. It's been very successful. Now, effective August 1st, I am now here being shared between Valley and Mount Ascutney. And we are, as Wynn mentioned, in searching for a permanent CEO that will be shared. So those are high-cost positions. So to be able to split that in half is a huge benefit to a small rural hospital. So that's all exciting. Our intention is to be able to develop, is to work with the accounting teams and to develop a tracking mechanism between the two organizations so we can keep track of what it is that we're saving over time. So we can share that with our board. And just because people do need to see that, and we will be working on that together. This will happen over time, not expecting all these savings to be immediately right out of the gate, but we're very encouraged and taking the first step. And with that, I'll turn it back over to Andrew.
Just want to highlight Vermont Act 119 briefly and just share our updates to our free care policies and procedures and our income eligibility thresholds and discount rates, and just communicate that we've worked in lockstep with the HCA in not only meeting the letter of the law, but I think the intent. Our policies reflect a more proactive approach in free care, and we recognize the importance of providing that to the people who've kind of fallen through the cracks. So proud to have updated it and worked with HCA on this piece. We also recognize that over the past couple of years, our free care expenses, if you will, or deductions have gone down over time, and we expect this to turn that around and bring us back to historical budgeted levels. Next couple slides are kind of some short form financials, just to give a brief overview. Our gross patient care revenue, budget to budget, is up 0.8%. Our deductions from revenue are down 3.5%. And our NPR plus, so I'm coining this term here, NPR, net patient revenue, plus fixed prospective payments, plus risk reserves, plus other population health management payments, is NPR plus. That's like an adaptive, what this MPSR benchmark is really talking about. So when we say NPSR, I just think of patient revenue, but when you say NPSR, from what I understand, we're talking about NPR plus FPP and these other items. NPR plus. That's going up 4.3%. Our other operating revenue is going up 12%, seems significant, and that's because of the HHR leaseback revenue and this pickup in 340B revenue. And for operating expenses, those are going up about 6% budget to budget. HHR onboarding again, as well as pharmaceutical and medical supply inflation and wage package and traveler expense. Yeah. And so our operating margin is $530,000 or 0.7%, and our total margin is 5%. Thanks to our friends at DH Treasury. The performance of the MIP is projected to be about 4.5% realized and unrealized next year, and the shared service allocation. I don't think I mentioned earlier, our FY24 budget, we had a $990,000 expense allocation, but this year in the FY25 budget, we have a $440,000 expense credit. So a huge swing and a huge impact on our bottom line, and really a great feature for our budget next year. Balance sheet real briefly, stable, and we just want to focus on our property, plant, and equipment. That's a priority for us. And while we're all here, our benchmarks, our budget against benchmarks. So NPR plus, commercial rate growth, gross price increase, and our operating margin. So we're at 4.3 versus the Green Mountain Care Board's 3.5, but how we came to that number is really important. We start the budgeting process April 1st, pretty much my birthday, best birthday present ever every year. But we all get together in a room with the clinical leaders and senior leaders and finance staff, and we talk about what historical trends, historical volumes, known changes, provider productivity, provider benchmarks and minimum standards, patients per hour, expectations, hopes and dreams, and we set a volume, as a group volume budget. And then we take that back to our greater management team and we say, hey, what do we need to do to make these volumes? All of the managers set their own volume budgets and their own expense budgets. So it creates this real culture of accountability. And I don't set anybody's budgets except for the accounting department. But I do provide feedback and guidance to all of them. But so we have the revenue, and then we have the expense to support those volumes, and then we consider our margins and the expectations of the board, of our board of trustees, of Dartmouth Health, and our own expectations as senior leaders and finance people. So this year, in consideration of the CON and the extra expense and not wanting to pass that through to Vermonters, we set a 0.7% operating margin, and then we back in to that to get the gross rate increase that we need to make all of this magic happen. So our 4.3% is a budget that considers provider productivity, considers volume, service mix, payer mix, and the price impact. The commercial rate growth, from what conversations with Elena, is the net increase and the net impact to commercial, the commercial price. So what's important for us really at MAHHC is the gross request that we're requesting of 3.5%. So we have a net realization with our from 3.5 times 2.2.
Use your screen.
Sweet. Oh, lucky us. Can you hear us? So we seem to have lost our screen.
We got
We
you.
can hear you fine.
Can you see my, let's see, the request-NPSR slide?
Correct.
Okay. All right. Well, I'm flying blind, but you guys can see, and that's what's important. We introduced this slide last year, realized rates of rate increases. And our model uses historical reimbursement rates to analyze the impact of rate increases. It's not perfect, but it's worked really well over the years. So our NPR increase is 4.3. We have a 3.5% rate increase, and the net realization of that is 1.9%. Because our total average reimbursement among the payers is about 55%. So Medicare, we usually see about 49%. And I'm happy to see that number because our cost to charge ratio is 48% on the cost report, so it makes sense. Medicaid is coming in at 27% of charges. Commercial on average among all of our payers is about 61%. And so a total 55%, 1.9. And the difference is 2.4%, and that's made up of volume, payer mix, service mix, and other stuff like debt-free care and risk reserves and population health management payments. The graphic on the right, admittedly, is old from last year, but it's still relevant. Our rate request is right smack in the middle of our historical range. And it really just shows how consistent we are, how reliable we are in managing ourselves and our financials. And to me, it says we're in the top 3, so I'll take it. Just a little extra perspective on our rate request. The realized, impact of the 3.5 is 1.9%, and it's lower than most inflation categories. It's lower than our wage package of 2% that company-wide in October, and then 1% for targeted market increases. Our benefits expenses are going up 8%. Our pharmacy inflation that we're seeing, pharmaceutical inflation, is anywhere from 3 to 10%, with our highest drugs like infliximab going up 4%. Medical supplies, we did some analysis. We think it's going up 3.4. Food's going up. All this to say, we're doing our part here in reducing inflation for Vermonters. Our rate request is lower than most expenses that we're seeing and that other Vermonters are seeing. So I think it's a fair ask.
Just we haven't really talked about travelers, which we do have on the last slide.
Sure.
We continue to operate with a number of travelers. I think we're around 20 travelers right now in our system. Essentially, our overnight nursing staff is almost exclusively travelers, despite our best efforts to recruit and attract nurses to come work at our campus. Obviously, we're right on the New Hampshire border. Dartmouth has done a lot of recruiting of new grads that are attracted to a higher acuity setting. So we've made a big investment, as you've probably heard from some of the other hospitals, and I heard in some of the presentations, working with the Vermont University system, and for us, River Valley Community College, creating a pipeline. So we're really working hard on growing our own caregivers, which takes time. So we have programs to become a LNA, an LPN, and an RN, which happens over a period of time, with agreements to stay working at us for a period of time for debt forgiveness. So that is underway and has been underway. And so we have the pipeline in place. And so we see that we will be able to chip away. One way at it over time is through that process of making sure. We also have a Dare to Care program here. So every summer we have usually about a dozen high school students here that spend 8 weeks with us to learn all about the career opportunities inside healthcare. And a number of those over time have gone into healthcare and have begun to come back to us over the years. So just want to point that out, where I've heard some other hospitals have been more successful in getting out of using travelers, given our location and some of the challenges we have that we're working very hard at growing our own, which is a more sustainable long term, because the market just has changed for a lot of clinical people who will move around or make economic decisions about where they want to practice.
The old 3 legs on the healthcare stool: quality, access, and cost. They're all highly related, highly correlated. As we continue to make investments in healthcare reform, looking towards the future of healthcare delivery here in Vermont, making incremental quality and access improvements, we have to consider the cost, and we have to consider how we're going to pay for that. And just as important, how are we going to keep this facility going? So we have to make investments in the property, plant, and equipment, and we need your help to do that. And speaking of property, plant, and equipment, our FY25 budget is $4.8 million, 2.3 of which is for the first phase of the CON. Phase 2 will be in FY26. But the remaining 2.5 million is for routine medical device replacement and some infrastructure critical upgrades, most notably our chiller. It's going. It supplies cold water to rooftop HVAC units, and we're already at max capacity, and it's time to change it.
It's at the end of its useful life.
So yeah, and when we do replace it, we'll be able to replace it with a more efficient model, and then we'll be able to upgrade our rooftop units to more efficient systems, really driving cost and environmental benefit down the line. Historically, we have been underspending in capital because of COVID. Bandwidth and supply chain was seriously impacted, and we're proud to report that we're on budget, $2.5 million this year in FY24. And I'll be honest, I'd like to see it go higher, but
because we have a significantly higher age plant as an organization because of those things.
Yeah. And so our last slide from me, just a brief overview of our benchmarks over time. Again, kind of illustrating our consistency and reliability and our narrow range of rate increases and our ability to manage costs here well at MAHHC. I'll turn it back over to Wynn to talk about risks and opportunities.
Yeah, so I'm just going to close out with the risks and the opportunities of our budget. Hopefully you can see the slide in front of you. We've already talked a little bit about the wage pressures that we face, and I think every hospital faces it, but maybe more for those of us near the New Hampshire border, closer to Massachusetts. It's a regional recruiting pool now. And so we have the wage pressures that have come upon us that we have to respond to, and we also live in a limited market for local talent as well. You know, Dartmouth has opened a new tower that has as they staff that up, demands a lot of new staff. We continue to, deal with the great resignation. We've had a lot of retirement of people, some of them retiring early. Our workforce is aging, and I already just touched on the reliance that we continue to have on travelers, despite our best efforts to recruit and retain folks. Another risk is just we're reliant on Medicare and Medicaid risk, that we need to perform well for that, and that the incentives that we get for population health management are the reimbursement that we get for that, or the bonuses we get for that, are less than the cost of providing those services. They're much needed, and they are effective at lowering costs overall, but it's a challenge, one, to staff them, and two, to finance them. We are, dependent on DISH as a disproportionate share hospital, and Andrew touched on 340B as an opportunity for us to regain some of the earlier revenue that we had before that market started to change dramatically, and Dartmouth has been particularly helpful for that. And so we're implementing things right now that we believe will come to fruition starting in January that will impact next year's budget. Under opportunities for us, our last slide before we go into the question phase. Really, the great opportunity for us is the integration and work that we will be doing over the next years with Valley Regional Hospital as we come closer together, and I would say into some level of alignment and joint management, and the opportunity to share even more staff back and forth between our organizations when one organization may have a better bench strength than another. Or you just don't need a full FTE of a particular employee, but between the two organizations we do. And that has been a good long-term relationship we've had, and we see the benefits of that coming. Obviously, our reliance and partnership with Dartmouth Health is incredibly important to us, and Andrew touched on a number of the things that are going on that will provide us better service, better back office at a lower cost. We look at IT integration, which we touched on as well, the moving to enterprise-wide software for accounting and HR and other back office functions, to be followed by moving to Epic. I think you've heard a number of challenges from other hospitals along these hearings, the challenges of working with Cerner around revenue cycle, and sharing information with academic medical centers is particularly challenging. I will say that we submitted our CON to go through this process in April, and we're still awaiting our CON approval. I think we're in the final stage. But I would just say that, if we look at things that Green Mountain Care Board and the state can look at, the CON process takes too long. It's not moving at the speed of business. We're in the planning phases for Epic, and not for Epic, but for our ERP component now. And so we need to get that approved so we can move forward. And as I mentioned earlier, that was one of Bruce Harmony's key opportunities for us, was to move to Epic. So any support you can provide on moving that CON forward would be greatly appreciated. Obviously, we are awaiting some new primary care providers that we have signed on, and they will be arriving. But as you also know, new providers take time to ramp up in their practice. We've talked about 340B, revenue cycle improvement. We've been doing a lot of work, despite the challenges with Cerner, to improve our revenue cycle before we move on to the Dartmouth Health platform. And we expect to see some improvement, and we are seeing some improvement in that. But again, that is incremental as well. And then just market share, making sure that we retain our market share. We have a very good reputation. We have shorter ER wait times in most places, so people seek us out. We have an excellent reputation around our rehab services. I don't think I go anywhere and someone finds out that I'm from Mount Ascutney and they begin to tell me a story of a loved one that's had care here from around the region and beyond. It's really quite amazing. And then one thing we just haven't really touched on and much down below is ophthalmology. We've long had an ophthalmology service here. We do a lot of cataract surgery, and historically that's been with our own employed ophthalmologists. As Dartmouth looks at specializing in certain services at its community hospitals that are more appropriate at community hospitals than at the academic medical center, we now have 3 Dartmouth ophthalmologists that each practice here a day a week and are in the OR providing cataract surgery, largely for Vermont residents at a lower cost than at the academic medical center. And it's just one example, along with more general surgery coming here to our general surgeons for appropriate general surgery. Again, Vermont residents coming back into Vermont for care. So those are the opportunities that we have that we're working hard to realize, and where we feel pretty confident about a number of them as we move forward, and we're keenly focused on them to make sure that we have been a very stable, well-performing hospital for a long period of time, even with a very narrow 1% margin over the past decade. But we are, if nothing else, we are consistent in our quality, in our service level, and our financial performance, and we're committed to continuing doing that, and looking forward to doing that in closer partnership with our new partner hospital under joint leadership with Valley Regional. So with that, I'll conclude my remarks, and we look forward to taking any questions you may have.
Thank you all for your presentation. I'll turn it open to the other board members for any questions they may have.
I can start off with a bunch of questions here. Just thank you so much. Appreciate the narrative, community needs assessment, presentation, and if you coming here, your comments, many of them consistent with other hospitals, and I think a lot of our own goals. So thank you. So I have a whole bunch of questions, I guess, or a few questions. We'll see where it goes. I guess a few things from your presentation today that you said that you're not open to new primary care patients. And I'm just curious what would happen if a patient goes to your emergency department and needs follow-up with primary care. Are you able to sort of get emergent people in or urgent people into the practice, or it's just you have to send them out of the region for primary care?
I'll take this one. So right now, if they are patients in emergency department, if they are already established with our practice, we're looking to get them in early for a follow-up. Those who are not established with our practice, we will try our best to accommodate them or get them follow-up elsewhere. But I think that's part of, we're trying to recruit more primary care providers to be able to open up our practices. We have, over the past year or two, we've had primary care providers leave, and we're trying to improve our access by recruiting more providers so that we can be able to capture these patients who do come to our emergency departments.
Okay. So not clearly defined that a patient who's seen there, who's a local patient without a PCP, would be able to get into your clinic for primary care follow-up.
Correct.
On a different topic, I'm trying to understand the reimbursement for your chronic skilled nursing facility patients, the swing bed patients, and the acute patients. I assume these all reimburse differently from Medicare and commercial. And I was wondering if you could give me some insight into sort of how that works from the various payer sources.
Want to take that, or?
Sure, I'll start.
Okay.
Maybe you can fill in the gaps. Medicare per diem based off of cost, swing. There's a swing per diem and a acute per diem that comes from the cost report. For commercial payers, some we have fixed fee schedules, and some we have percentage of charge. For Medicaid, I believe it's like a per diem as well.
Just payment, right? Is it a prospective payment?
The DRG,
Yeah,
I think so.
Yeah.
So for commercial patients that end up in a chronic skilled nursing bed, are they paying? Is that being paid out of commercial insurance rates, at a higher rate than a skilled nursing facility, or is it a similar rate to a typical skilled nursing facility?
Well, there are so few, honestly,
happen
commercial
very often.
swing,
Mhm.
like, I can't even think of any, to be honest. But it would probably be depend on the payer and depend on the contractual agreement.
Yeah, I can
That's-
speak more to other hospitals that I've been at. And as Andrew said, it's rare that you have someone who has commercial who ends up in a long-term swing situation. But what will happen is you may have to negotiate a specific rate with that insurer. If it really will depend on what the person has for a commercial plan. And usually what we would do is maybe have to do a single case agreement. It would end up being a daily rate. I'm sure it would be very competitive with if they went somewhere else. We don't see them often. We don't expect to make money on those patients who just want them cared for. And I think in many cases, they end up probably going into the rehab unit if they need longer term care.
I can probably speak to that from a kind of frontline perspective. A lot of our commercial payers don't receive chronic, long-term kind of skilled care here, like nursing home level care. If they have skilled needs, they will continue to, commercial payers will continue to reimburse as per the contractual agreement. But once their skilled needs end and they don't need more PT, OT, or intensive nursing care, then a lot of the commercial payers will likely stop their coverage. And that doesn't necessarily mean we would immediately discharge the patients home. We would oftentimes plan ahead and work with the families to determine whether it is safe to go home. And if they do need to stay here for us to find a better long-term solution, then we would keep them here and we would work on applying for long-term care Medicaid, work with the family for other solutions so that it's sort of best and safe for the patient.
Okay. Thanks for that perspective. A couple things from the narrative that I would just had quick questions on. There was a discussion of a GI surgeon, and I was trying to figure out if that's a gastroenterologist or a general surgeon.
That's a gastroenterologist. We have a couple of that come here on a once a week basis right now, and so that's for the GIs.
And that's for colonoscopies, is what that was referring to. Okay. Another thing from the narrative is I'm trying to understand sort of your engagement and perspective on OneCare. There's discussion of inconsistent and untimely data reporting that's not communicated effectively, and that PHM payments are eaten up by participation fees and risk pooling. But then you sort of go on to note there's a bunch of components of what I would think is a modern healthcare practice should have, like social workers, case management teams, patient insurance liaisons that are not covered by PHM payments. So I'm just trying to think, I'm trying to understand if what are your interests in? I mean, it sounds like OneCare, the way this is written, is not a particularly beneficial for Mount Ascutney Hospital, but yet you're signed up to be part of OneCare's network. So I'm trying to understand how you approach this decision and this relationship.
Yeah, to be honest, our financial participation with the ACO is not beneficial, but the underlying activities and reform efforts are important to us, and we believe in them, and we want to pursue them. Fortunately, Blueprint Community Health is funding a larger portion of our healthcare reform and community engagement work, community health work than OneCare.
I mean, Blueprint is very important to us and helps us provide some of that infrastructure. I think one of the challenges that I see with OneCare is that we have patients assigned to us that are not in our panels. We're assigned patients regionally, so we're responsible for sort of the health and well-being of Medicare patients that are not ours. So it's an interesting model that I don't think other states have. I'm not familiar with it. So it's it's a challenge, I guess I'd say, for organizations, especially our size. But we believe in the long game of it. And so we are committed to it, and we invest a lot in it, and spend a lot of time and effort around it to make sure that we are really thinking about the population health. And it's so we're all in. It's just it doesn't pay us as well as it could and should.
And when you say the long game, can you expand that just briefly?
The long game, the long-term perspective of having a healthier population that's getting the right care at the right time and the appropriate mix of services to make sure that people stay well and out of the hospital in high-cost care settings if they're given the skills and tools they need and the wraparound services. Overall, we all believe that the cost will be lower, and so we firmly believe in that. It's just when you are an organization our size with our margin, it's and we're not unique. This is true for everybody. So it's not like we're precious and rare. And I think everybody would probably in Vermont, especially small hospitals, probably say the same thing. We all believe in it. That's why we're here. That's why you're here, is to really look at the long-term health of the state and its population and the viability of the delivery system. So we believe that and we support that, but we also call out the challenges in it.
Yeah. Andrew, I really appreciated your discussion about terminology with things like NPR and how we use NPR and how you use NPR. There's a bunch of other terms that I think I picked up through your submission that fall into this category that I think we need to work to clarify a common understanding of definitions. One is prices. I think we look at prices as what is paid to an organization for healthcare services and look at charges as what you charge. So when you look at things like RAND pricing, that's not RAND charges, that is what is paid to the organization. So a lot of the health price transparency work is really the not charges, but prices and what is actually paid to organizations for services delivered. And so I think, at least myself speaking, and maybe we need to have a broader conversation on that. That's how I would use that term.
That's fair. And, even CMS, the price transparency rule is charges, not reimbursement. So when you say price, we're thinking reimbursement. I agree.
Yeah, price. Yeah, I'm thinking. Yeah, what is reimbursed? Yeah, so a change in price, I think of as a change in of what would be paid for said services, not what is the, not the sticker price, but the sale price that's actually the one that's paid for. Yeah.
And that is a very fair point. And the challenge with that is that every single person that walks through the door that service may be paid for differently depending on their insurance.
Correct.
Not just what you're saying, but it's a complicated industry just for that very reason.
Yeah.
There's a couple things in the workbook that I don't know how familiar you are with the details of the workbook, but I'll describe them to you and see if they make sense to you. When I was looking at your inpatient commercial revenue projection from 24 to 25, it's essentially flat, $500 more inpatient commercial revenue. And in outpatient commercial revenue, I'm sorry, that's outpatient commercial revenue, essentially flat. Sorry, I have my notes backwards here. Your inpatient revenue has a growth of 23%. Your outpatient revenue is totally flat, which confused me. If you're working on access, increasing ophthalmologic services, increasing, trying to get people in the clinic and getting a rate increase, how your commercial revenue is staying flat. To me, I would think that's a decrease. If you have increased price and flat revenue, that would mean to me a decrease in utilization. So are you predicting a decrease in utilization for outpatient commercial services?
It depends on the service mix. I'll comment quickly on inpatient. You know, we have an increased projection for volumes for our acute admissions at the expense or offsetting swing admissions. So maybe that speaks to the commercial piece. And also, we fill out these workbooks using our revenue models that rely on historical reimbursement rates, payer mix, volumes, service mix. So it's not perfect. I think by and large, you need to look at the big picture when it comes to those workbooks. You know, we tried to fill it out the best we could, but every year it's a new one, and we didn't have a lot of time. Last minute changes. So, you know,
Okay, I can understand that too. I mean, I think we're trying to look at things broken out more so we can understand where growth and expense not your side of expense, but also system expense are. I guess my concern when I saw that was, is there an initiative to try to move outpatient commercial services out of Ascutney to other DH hospitals?
No, no, I don't think there's any concerted effort like that. We want the commercial to stay with us.
Yeah.
Okay. So in and around sort of this topic of RAND and prices and commercial expenses, one of the things that I think is striking for Ascutney in the RAND data, and we have some other confidential data that sort of directionally supports this, is that you have pretty dramatically high outpatient and inpatient prices. So I don't know if you've looked at the standardized pricing in the RAND data, but Ascutney is in the I don't have the decile here, in the 9th or 10th decile, with Dartmouth actually being 22% lower, and Springfield, your other sort of closest hospital, being 31% lower. And for inpatient prices, Dartmouth is 23% lower, and Springfield's actually a third of the price, 66% lower. So the inpatient thing I'm trying to understand, I assume that's somewhat due to this kind of unique inpatient mix that you have, that somehow you're not able to charge, I would assume. But what do you think? I guess, what do you think is driving that inpatient and outpatient price that we see in RAND and other data? And these are, again, paid prices, not charged prices.
The inpatient is 100% the fact that we have a distinct part unit for rehab.
Excuse everything.
Yeah, a 14-day average length of stay versus 3. And it's highly complex, comprehensive services. So the inpatient is 100% the DPU. And for outpatient, I don't have a great answer. I think it's, our prices have been established long ago, and we try and work to improve them best we can. We did a major restructuring in radiology in 2020, where we reduced our gross prices by $1.5 million. So we do try and address those. I would just say we're a critical access hospital with a distinct unit with the DPU. So I think that
a critical access hospital. What was with a
distinct park unit would be the rehab skews it
for the inpatient, and then the outpatient. Critical access hospital, but again, Springfield's down the road. I just put my notes away on that. A third less. Is there, I guess the question I have is, when I looked at your community needs assessment, it had the second highest pressing health need was the cost of health insurance, and the third was the cost of healthcare services. So I'm trying to figure out, how, and this I think is a huge balance. And we come across this, this is my second year doing this, and this was clearly a driving conversation on several hospital budgets last year, is how do you justify high prices in your community charged to the community members, balanced with being financially stable and having a hospital in your community? And so I guess my question when I saw that is, are there things that you can do, or what are you working on? How do you approach trying to reduce the price of healthcare paid by your local residents for your services there?
Well, I think a couple of things that, you know, as you saw in our presentation, we're making some active changes between partnering with Valley to bring some costs down. As far as what patients pay, the Act 119, we will be more aggressive with getting people on on the financial assistance plan. So the cost to the consumer, one would think, out of pocket for the patient, we have zero increase budgeted for that. If anything, we are anticipating that our charity care, our financial assistance will go up this next year. You know, our overall, our margin is very, very low, you know, 0.7, enough to keep us going. You know, some of the challenges that we do face, again, our costs are fairly fixed, but our volumes compared to Springfield are, I would imagine, significantly lower. So you take that fixed cost and you just aren't spreading it across as many people in the first place. So the whole point of critical access is to cover your cost. And while on the global scale, our cost might be lower if you looked at us budget to budget, but when you divide it by the number of people that we actually see, then the cost per unit may actually be somewhat skewed. And that may be partly what you're seeing there. Fairly new, so I'm just kind of speaking off the top of my head here, but it's historically what I know. Yeah.
I mean, these are hard questions, and I think that these are the things that you know, as a board member, you have a lot of trouble sleeping at night, is trying to balance, you know, places like Ascutney, where, you know, it appears there's pretty high prices. You provide a valuable, you know, resource in your community, and how do we sort of try to work towards a place where, you know, these prices can come down, you know, and operational efficiency improvements are, you know, are a huge driver of that. So I look forward to sort of seeing the gains from that over time. I think that's all I have for now. Yeah, yeah. Thank you so much. Thanks. I appreciate it a lot.
I can jump in next if that's all right with you, Chair.
Yes, please.
Could I just ask that you, since we can't see you anymore, if you would just announce who you are, who's asking the question, that would be helpful, just so we have reference.
Oh yeah, this is Tom Walsh, and I had forgotten that you couldn't see us. I'm sorry about that. That can be frustrating.
White blank screen that we're staring at.
I've been there before, and yeah, sorry about that difficulty. So, you know, as Dave was just saying, yeah, I have some questions. I think some of them may feel hard as we go along, but I want to start out by just commending you on your patient experience scores and the quality initiatives and focus that you've brought consistently. I moved to the Upper Valley in the late 90s to work at Dartmouth at a multidisciplinary spine center. And we worked closely with Mount Ascutney there. And I've long been aware of the good work you're doing. I also wanted to let you know that I appreciate the tight targeting of your request. I don't remember the slide number, but I did notice that you're in the top 3 regarding consistency with your budget increase, your budget requests year in and year out. And I've also noticed that the variance between the budget you submit and the actuals at financial year end are among the tightest. And I think those are all great things. Dave asked about your comments regarding the ACO. And I had a couple questions there, but the one that persists that he didn't quite get to, I want to make sure that I did my math correctly. You state you receive roughly $220,000 per year for that participation, but then you list several fees, and those fees, if my math is correct, amount to over $1 million a year. So it read as though you're contributing 4 to 5 times what you receive in pure dollar amounts. Does that match with your experience? Is that what you were trying to imply as you listed those things?
Essentially, yeah. Our PHM, per member per month, population health management payments, around 220K a year. Our participation fee, the infrastructure fee, is around $400,000 a year. So right off the bat, we're at a loss, and then there's the risk. So at the time we were budgeting, we were on the hook for 600 grand.
Have you discussed this with OneCare?
We asked, because it was delayed settlement response. This is from 2022 or 2023, excuse me. And it was not the final number, so we were trying to get the final number.
Okay.
We reached out to OneCare to talk about it, but
yeah, I hope that you do. We haven't seen, I haven't seen those type of fees and the total received broken out that way before with other hospitals. So it was
some claim, or that they list as part of their distributions, like Blueprint CHT money, which is Medicare money, but it just flows through them. So I feel like they're claiming it in the PCMH money, but we would get that anyways.
okay. Well, it was a notable part of your narrative, and I just wanted to follow up on it. I'd like to turn toward the community benefit section of the narrative, and in that you describe many volunteer activities and participation with Meals on Wheels, and you also mentioned the Windsor Connection Resource Center. Could you tell us a little bit more about the Connection Resource Center, please?
Yeah, so we have a, excuse me, this is Dr. Herbert. So we have a Windsor Resource Center down sort of Main Street, downtown Windsor, and that houses where our Volunteers in Action team, and they, it's led by a community programs manager, Amanda Jordan Smith, who, her role is to really facilitate and manage a large group of volunteers that will help with Meals on Wheels, help with transport, help really provide a lot of community services across our Windsor region. That Windsor Resource Center also houses other resources like HCRS and counselors from Turning Point to provide those services at the community level. And so they also provide other services, whether it's to address food insecurity, clothing, and where families, individuals from the community can stop in and essentially pick up things that they need.
So there's a food shelf, there's a clothing bank. She also coordinates Veggie Van Go in our region.
Yeah, and then we have a excuse me, a MAHHC Health Connections, which a team run by Kelly Rapp, who helps, who works in coordination with Amanda Jordan Smith and the Windsor Resource Center, and they help patients sign up for, if they don't have medical insurance, they will help them enroll, assist them enrolling in medical insurance, or if there's medications that they can't afford, she will work with the insurance companies, work with the pharmaceutical companies, try to get them on, try to get discounts or coupons so that it makes healthcare and medications more affordable, or maybe even free for patients, or is a resource for our Windsor region here.
She also has some grant dollars that we have that allow for dental care and emergency dental care and some other things. So it's the nexus in our community, and it's embedded deep in downtown where folks most in need of those services can easily and comfortably access them. And it's been a very successful model for us to really get at the core of some of the socioeconomic challenges of our main community that we serve and beyond. we do through Historic Homes of Running Mead's Kitchen provide meal. We do all the Meals on Wheels 5 days a week for our community. I think we had 75 to 90 meals a day come out of that kitchen, and we lose money on every meal, but again, not much, just incrementally, but it's an important key service, and we're the ones that can provide it through our kitchen. So
I appreciate the further explanation. It sounds like a lot of good is going on there. The Lown Institute is a think tank that calculates a hospital's community benefits and compares that to their tax exemption dollars. And in 2023, according to their calculation, your community benefit amounted to about $1.9 million, while tax exemptions totaled about 3.2, or a difference of a deficit, receiving more in tax breaks than providing in community benefits, of $1.3 million. That might be something to, that fair share index. I know you're focused on doing a lot of good for your community. That might be something that would be helpful to look at.
Yeah, I'll comment on that real quick if it's okay.
Yeah, of course.
From Schedule H from the 990. And
My apologies for interrupting. I'm so sorry, Mr. Hearing Officer. I lost you guys for a second. So if Mr. Garami can start again, I apologize.
No worries. I did a little bit of digging into the Lown Fair Share Index, and if I'm not mistaken, I think the data comes from Schedule H and the 990. And having helped fill that out for the first time this year, I think I have a little bit of insight. That doesn't, I don't think that includes, our One Care Vermont dues or our spending in our community health team. I don't think it includes our HHR subsidy or our healthcare reform risk or bad debt and free care. So it's a good measure to look at, but I'm not sure that it's all encompassing.
Mhm.
Plus we historically underreport those things anyway.
Yeah, and a lot of what's reported on the 990, depending on what he's looking at, there's the net community benefit or the gross. So
Great. I'm glad you're getting more familiar with it. I think it's they've been working with it. They've been doing it for 3 or 4 years now. And I think they continue to refine their methods, and the more communication we can have back and forth about that and learn what is contained in those numbers, I think that's for the better. So I wrote down the things that you were just sharing, and I appreciate that. I want to turn to your profit and loss statement, if we don't mind, and just one question there under the summary statement of revenue and expenses. 15 million of the 23 million reported there is other. So over half of what's contained there. I was wondering if you could just explain a little bit more to us about what's in other in that line item.
other operating revenue.
Yep.
There's big chunk is 340B. It really, I think it's 1.5 million just related to HHR's lease back revenue. Maybe it's 2. Blueprints, grant revenues are often reported as other. So grant revenue is also has corresponding or correlating expenses. So it's really pass-through revenue. That's a big piece. Foundation program revenue. That's a big piece.
Cafeteria.
Cafeteria is bumping now. Yeah, cafeteria revenue. Sale of pharmaceuticals to employees. It includes, well, depending on whose P&L, but it can include the fixed prospective payments, at least on our P&L. I'm sorry, I'm not seeing the P&L that you're talking about, but yeah, those are some of the bigger items.
Okay. Thanks for clarifying. I know board member Merman also asked some questions about the RAND data. So I've just got one that he hadn't asked already. And instead of looking at the standardized prices the way that he was, I'm looking at prices relative to Medicare. And your total facility price is listed at 203% of Medicare. And the break-even price that they describe and calculate is 127%. That's a gap of 76 points. And that gap is considered an assessment of efficiency. And to be honest, 76 isn't that bad. We've seen much higher. But one hospital last week in Vermont had a gap of 11 points. And so I'm just wondering what you make of those numbers and your efficiency, productivity, and what work are you doing in those areas?
Well, I can comment that we are one of, this is what Dave told me, but we're one of fewer and fewer reimbursement mechanisms are charge-based, and some of our top commercial payers are percentage of charge still, which is really, really good, for us, frankly. It helps pay for the Medicaid underfunding and Medicare sequestration. In the end, and Medicare Advantage plans. So maybe it's a measure of efficiency of how good we are at contracting. But that's one aspect.
Yeah,
that I can
and
comment
I
on.
think, I personally have not looked at any of this data, did not know they existed, so maybe that is something in the future that Andrew and I can start poking into.
Great.
Sounds
I
like
think,
there's interesting tools out there.
yeah, and I think you do a great job describing the quality of care that you deliver and the efforts that you put into it. And seeing similar efforts with efficiency and productivity would be reassuring, as also Dave pointed out, your prices are quite high relative to places around you. It also, in your narrative, you had a statement, and I'll quote, it's on top of financial pressures, regulatory pressure to reduce costs and increase investments creates a conflicting and uncertain operating environment and only adds additional administrative efforts and costs. And I was wondering if you could help us understand that. I'd really like to make sure that I understand what you mean with that sentence.
Well, as two executives who've worked outside of Vermont, who probably best comment, I think.
There are some administrative burdens across the healthcare industry as a whole. I mean, one classic example are the Medicare Advantage plans. Getting a claim through, you're not just like Medicare. You have to get approvals. You have to, you got to call and get prior auths for a lot of things. I know other healthcare entities, smaller places that have actually had to hire people to do just that. I'm sure we've had to do that here. So there are some additional FTEs that you have to pay for to meet that need so that the Medicare Advantage plan can save some money. Have you really saved any money at that point across the entire healthcare continuum? I would say no. There are other, when you think about all the reporting for quality, there's software involved, there are staff that you have to hire to analyze it all good work. But again, there's a cost. Putting all this together, I will say I'm from New Hampshire, live free or die. And we don't have this level of oversight in New Hampshire. And I think about the hours that Andrew has put in and Wynn has put in. I'm new to the game. The team in general has put in to prepare all this. you know, there are costs involved with that. Whether they're good or bad doesn't really matter, but there just are costs. So those are
Okay.
the sorts of things that we just,
Yeah.
that we're thinking of.
And there's just more and more reporting required,
Mhm.
and a lot of people ask for similar data, but not the same data.
Right.
Data sets that are different,
Mhm.
where, you know, if everybody asked, you know, we could agree on the same data set would make a lot easier, but
Right.
especially, you know, we have to put the same amount of effort in. This is a gross, somewhat of an overstatement, but as a critical access hospital, we have to put together the same level of budget detail with a very small team
Mhm.
that UVM has to put in that has a huge team.
Right.
It would be like asking DH to do it. So
Mhm.
it is a, you know, it's part of how we operate these days, but it takes a lot.
Mhm.
You know, so, and a lot of organizations, a lot of government entities ask us for information, federal and other.
Right.
There's just a lot of reporting.
Yes.
Okay. In the contingency plan section of your narrative, you state that if rates are not approved, you'd be forced to cut services because, and again, I'll quote, we only provide what the community needs. And I'm wondering how you know that with such certainty.
Well, we are actually just finishing up our three-year community needs assessment. It's just finishing up, so we'll have a better sense of what, you know, we'll have the community needs adjusted or changed or not. I mean, we do a lot of community-based work, a lot of which is grant funded, some of which is grant funded as well. But, you know, we've over time, we've made decisions of things that we are or are not going to do anymore. You know, sometimes we have specialists that we underwrite to a certain degree. Is it worthwhile for us to provide that level of access at that cost? And as you know, specialists are expensive. An example is we have an interruption in our neurology service right now, and we've brought in a locums to make sure that we continue that service, not at the same level, but to make sure that our patients actually have access, because they won't get access anywhere else, and they're depending on that continuum of care. In a different situation, we might say that we just can't afford to do that, which then goes completely against all the population health work we're doing to keep everybody healthy and in the right care milieu. So, you know, it's you know, it's just like your house budget. You only have so much that you can do with the revenue that you know, the salary you have. So, you know, luckily we've been able to, you know, we're conservative, but we're forward thinking, and so we try to figure out, you know, what we can afford to do and try to get creative, just like everybody else on this call does every day. It is everyday decisions that we're making to try to make sure that we keep, you know, one of the things we have been is we have been stable, and despite our margin, and you know, we try really hard to keep that and deliver where we can. Luckily, we do have a partner in Dartmouth Health that can, you know, depending on what the situation is, lend us some level of support, but even they are stressed as well. I think there's opportunity with Valley that I think, you know, as we come into next year's, you know, when we're here next year, I think it'll be very interesting for us to see where we are in that process and what we realize and what we foresee as opportunities to collaborate and lower the cost structure.
Yeah.
I think
that's
conversation with us will be very interesting.
I'm looking forward to it. I did look through the 2021 community needs assessment, and the top areas were mental health care, the affordability of care, care for patients with substance use disorders, the socioeconomic status factors affecting health and well-being, dental care, and child abuse and neglect prevention. And so as a regulator, it'd be reassuring to me if I'm signing off on an overage above guidance to see that the overage was going toward community needs. And are there priorities, objectives, key performance indicators that align with those community needs? And so I look forward to next year and hope that we'll see some more of that. And just close out again by just saying again that I really appreciate the high quality standards and the scores that you're receiving there. It's a job well done. Thank you.
This is Robin Lynch. I can go ahead and go next. Thanks for joining us today, and I'm sorry about your tech problems. That sounds frustrating.
Actually, Robin, you're the one person we can see.
Oh, great. Hi. Oh, sorry. Now my dog's barking. Some of my questions have already been answered, so I just have a couple. Thanks for outlining on slide 20 the expense savings you're expecting from the shared oversight and management with Dartmouth. One question that I had, I know this is a work in progress, was sort of when you would expect those savings to hit the budget, what your assumptions are for them in the 25 budget, and just give us a sense of timing for those savings.
Well, for the budget, we have a 0.5 FTE for CEO and a 0.5 FTE for CFO. So an immediate, savings of about $500,000. And we are already sharing, our lab manager, our respiratory manager. So that's baked into the budget as well.
That's been ongoing for a few years. I'm not sure how long that's been going on. That's been built in for a while.
Right. And then I did notice also on that slide that there were some supplies and other joint purchasing stuff that had been we've heard about for several years. So appreciated that being listed as well. On page 5 of your narrative, you mention your current recruitment for a pain clinic provider. What was your budget assumption related to that position?
Yeah, we did not include it in our budget because we didn't have anybody lined up.
Okay.
That actually, Robin, going back, that would be an example of making a decision of whether or not to pay a lot of locums money to provide that service. And that service is missing in this region as well. I believe Springfield also may have lost their provider as well. So it's a shortcoming, but it's trying to find the right anesthesia person to do that service or physiatrist is challenging. It's definitely a need in this community. But again, we couldn't pull it off given the quotes we were given from some of the outside groups that provide this. Took away. It wasn't profit. It was a huge loss to be able to do it that way.
Well, thank you for the clarification. Sometimes it can be hard to tell in the narrative exactly what's happening. So I appreciate that.
Continue to pursue it. We continue to pursue it to bring it back online because it is important. So there's and from our recruitment side, it's in our focus and looking at niche providers.
Great. In your narrative, you also discussed that you've had some increases budget to budget in pediatrics and primary care, 13% budget to budget for peds and 9% for primary care. I wondered if you could just speak a little bit more to how you came up to your estimates, or is that because you currently have hired those providers? Just give us a little more sense of how that got built into the budget.
So we hired 2 additional pediatric nurse practitioners on this campus, on the hospital campus, and as we also foresee the slowing down of one of our pediatricians as she nears retirement, and so that is where you see a piece of that increase there. I will say and that has allowed us to be one of the places we have ready access where there is no wait is actually outpatient pediatrics. And so we have that, and we do a lot of work, as you're probably aware, with the schools. We have a physician liaison, Dr. Mary Bender, for the Windsor schools, and Dr. Claire Grabitko for the Woodstock schools. So work very closely with our schools around that. So we do have capacity there, but it was also in preparation for a transition, trying to avoid what's happening in other areas where all of a sudden you have an absence.
Right.
And in primary care in FY24 budget, we had new providers starting. We had a ramp up factor. Now in 25, they're fully ramped up. They're rock and roll.
And the other piece is obviously, as we look at, the MGMA, what physicians and providers are being paid and being able to stay market competitive.
Yeah.
So that we keep our providers, we really had to, and we had for a couple of years still been delayed in our increases, had to do some catch up work.
Okay. Thank you. Let me just check my notes here. Oh, one more. Okay, I think that was it for me. I think everything else I have on my list is answered. So thank you very much for your time.
Thank you. It's nice to see you.
I don't know if you can see me, but I was going to go next. This is Jessica Holmes. Are you able to see me?
No, but you're coming through loud and clear.
Okay, perfect. Well, thank you so much for the presentation. And again, I'll echo my colleagues with congratulations on a lot of the quality achievements and the new accreditation for the outpatient rehab therapy. That's impressive, and I can imagine that was a lot of hard work. I have some questions that I think they're just clarifying questions that I need to understand about the rate, the request. So from my understanding, it's a 3.5% charge increase. Can you just describe how that balances out across inpatient, outpatient, and professional?
Yeah, it's
How to be applied.
Yep. Yeah, for inpatient and outpatient across all provider clinics, across all inpatient services, ancillaries, it's 3.5 across the board, except for pharmacy. Actually, we have a markup policy, cost plus. So we're not applying it to pharmacy. Everything else.
And professional too. So across inpatient, outpatient, professional.
All professional, inpatient, outpatient. Yep.
Okay. And in the narrative, it described that it was 3.0 was what was needed, but the 0.5 was related to the CON project. Is that correct?
Yes.
Okay. Assuming that gets approved. So so that would be in the charge request, assuming that gets approved. Aside from the 0.5 increase in the charge related to the CON, is there any place else in the budget that we would see the approved CON project? For example, on the revenue side, is there any projected increase in revenue cycle management performance that might increase revenue? Or are there any cost savings on the expense side that you've booked into the budget related to the CON project?
We've tried to align our budget as best as I could with the CON application. The first phase is the ERP, so administrative, and there's actually the operational expenses that are in the budget that relate to implementing the project. So mostly expenses.
Okay, so there's no estimated revenue improvement related to revenue cycle improvements, fewer claims than anything on that regard.
That's this 2026.
Yeah.
That's with the EHR.
Okay, that will all come with the EHR. So there's nothing that you're expecting in terms of, it's only operational expenses that are added, no cost savings. I thought you, in your description, you were very excited about this, talking about the upside potential of this. I was wondering where we might see it in the budget.
Yes, I am excited.
I believe you, but I'm just trying to figure out where the excitement might land in the budget.
We haven't quite figured out the details of who's going where. So we're kind of level budgeted right now.
Okay, so in the budget, we have only costs associated with the CON, if it's approved. Yep. Okay, thank you.
I just want to say, I think also when you're thinking about sort of revenue cycle If you've heard from if you've heard from other hospitals who have done EMR implementations, it's not always an instantaneous improvement. There are usually months of cleaning up things, despite the fact that we're not the first to go live with DH on our ERP. You know, there takes time to fine tune those projects. So I think we'll see better revenue cycle work, especially when we bring Conifer in as part of that. And we might see something toward the end of the fiscal year, but I think we'd be naive to say that right out of the gate we're going to see savings, given the fact that it's our revenue cycle.
I actually I forgot something. I'm remembering something now. Part of our shared service credit allocation is or includes like a rebate on the finance piece. So for AP and GL and bank recs and stuff, I think it's about 140 grand in
FTE costs.
Yeah, well, in the shared service credit because of the ERP phase 1.
Okay.
So there is some, but sorry.
And I just wanted, just that I have a more of an apples to apples understanding of the charge and the impact underneath the charge across payers. And I know you had a slide up there, but I actually was just going to ask you some more specific questions about assumptions here. So can you just tell me what rate increase you assumed for Medicaid Vermont?
We have 1% is the net impact. I mean, it's 3.5 across all payers, the gross price, and we typically see 27% reimbursement or payment rates from Medicaid. So baked into our budget is about a 1% increase.
Yeah, I'm trying to unpack a little bit about what you're assuming for Vermont Medicaid versus what you're assuming for New Hampshire Medicaid. So if you can, maybe we can follow up with me. This seems like a blended Medicaid from historical performance. In the narrative, it said you have no indication of what Medicaid reimbursement will be at this time, although we are hearing that there are no increases budgeted. So I'm trying to understand what the assumptions are in the budget according to, you know, Medicaid rate increases from Vermont, Medicaid rate increases from New Hampshire, to get at that, what I'm perceiving as a blended rate, but it sounds like off historical, you know.
Yeah, we don't have the most accurate pinpoint for every payer. We do kind of big number, big picture estimates using a reimbursement and revenue model that we've used over many years. It's not perfect, but it's pretty close, you know.
Well, it's a math model.
Yeah.
It's a math model. The reality of it may be that we don't get that 1%.
Yeah. Historically, it's brought us in right about where we expect to be, though, as you've noted.
Okay. So you're not actually, it doesn't sound like you're actually using actual rate increases as described by Medicaid. You're using this model.
Yeah.
Okay. Is there any assumption in there under what you're assuming for Medicare Advantage increases in rate?
They're lumped in with Medicare, and they pay Medicare rates, unsettled Medicare cost report rates. So like they'll pay the interim payment rate from a previously filed cost report or per diems for inpatient, acute or swing. So just kind of follows the Medicare bucket.
Okay, so would the assumption be what the Medicare market basket increase is, or is there a different assumption?
Medicare pays based on cost. So as our costs go up, our Medicare rate goes up.
Even for Medicare Advantage? I guess that's what I'm trying to identify the difference between the Medicare Advantage. And I understand for a critical access hospital, the cost-based reimbursement for traditional. I'm trying to understand the assumption that you're making about Medicare Advantage.
Yeah. Medicare Advantage programs typically will contract with critical access hospitals to pay either the Medicare rate or maybe a little bit above because they don't cost settle. They pay that. So they'll use the letter that Medicare sends us saying, here's your new outpatient payment rate and here's your inpatient payment rate. And they'll use those exact numbers. Yeah. So there's always a lag. Yeah.
Got it. Okay. I understand. Interesting. Okay. And I guess my last question is related to, I'm just trying to understand, trying to reconcile a little bit of what I've heard and read in the narrative. There was some discussion earlier about maybe the relative prices being high because compared to other hospitals in the area because volumes are low. And then there was discussion about, having to cover the fixed costs with lower volumes than other potential hospitals in the area. And I also heard and saw, the access challenges that your community faces and could see in the submission, the long visit lags, and actually you showed some of that data. And we heard about primary care being closed to new patients. And so I'm trying to reconcile the description about somewhat low volumes, harder to cover fixed costs, access challenges, and then the productivity that does seem to be at or below 25th percentile in the submission. So wondering how that all, if you could help me understand that set of information.
That's a lot to unpack.
That's what I'm trying to do. Yeah.
Let me see if I can unpack part of the suitcase for you. So we have had a loss of some providers and we've had some false starts, as you've probably heard from other hospitals. You bring someone in and then they don't stick and they don't stay. So you've got access issues. We believe that in working with especially our primary care leaders, that we will be opening back up to patients starting in September, given the new providers that are starting with us. We have been working with our providers around productivity. Historically, they are largely hover in and around the 25th percentile. None of them are actually on an incentive plan like you would see in some other hospitals. Our physicians and providers, that's the way they practice, and trying to move them is a concerted yet thoughtful effort in doing that. And we have made some strides in changing schedule templates and opening some things up to absorb. And I will say, when we take new patients, if someone comes to work for us, is a new employee and moves to the region and needs a primary care provider, we do take them. If you are a pediatric patient who is maturing and needs an adult provider, we will take you into the practice and figure out how to do that. So when we say we're closed, we are closed for pieces of it, but there are some access issues there. So it's a balancing act, and we're trying to, from a productivity perspective, work our way there. And we expect, on average, our providers will be above the 25th percentile coming into September, is the RVU data that we're looking at right now. And so that's our target, is to continually move us toward the median. But it is something about Vermont. There is a practice pattern. There is an expectation of how much time you're going to spend with your patients. The challenge of the EMR that we have right now. I will tell you that, a lot of places, when they put in a new EMR, providers in particular say, oh, woe is me, but they've all worked in Epic and they can't wait to get rid of the friction that happens in the system when they work with their DH colleagues and they're on disparate systems. So I think you'll see some of that through concerted effort and evolution incrementally change, but there's not going to be an overnight flip of the switch.
Okay, but your goal is to move to the median, it sounds like, across all the specialties?
Over time, yes.
Do you have a time on that? What is the expectation for 25, fiscal year 25?
Is to be somewhere between the 25th and the 30th percentile on average.
Okay. And that's what's assumed in the budget?
Fair to say,
Yes, yes, I would say that is fair to say.
Let me just see if I have any other questions. Oh, just one question about the access. I noted the referral times. There was not a lot of data on how long it takes to schedule a patient, and I was just wondering if that was why that was.
Well, it's a 2-week period, and depending on the service line, or if it's like the radiology, really dependent on who walks in the door.
Can you clarify that again? I don't know if I quite
Sure.
followed.
Yeah, no problem. I just was noticing, so on the referral lags, for example, for all primary care, the total number of patients was 0, and the percentage of appointments scheduled within 3 business days of referral was also 0. But then below, for the visit lags, there were 57 total number of new patients, and then there was, the lag time associated with the scheduling, or with the visit. So I was trying to figure out, there were 57 new patients that came in during that time period, but in the referral table, it said 0, and then there was 0 scheduled. So I was trying to understand if what the submission was there and why there wasn't referral information. Does that make more sense?
It does. I
Yeah.
can't answer it. Some of that might be that the pediatrics are lumped in there, and that's a piece of it. But why don't we, that might be something we need to clarify and get back to you on.
Yeah, and I just, I guess what I would just say is that'd be helpful. And then just for next year, it is important for us to understand, some of this access. This is our way of getting a sense of access. And so referral lags, as well as visit lags, are important components of that.
Yeah, no, they're
understanding, so.
important, they're important to us, and as I think Dr. Ip noted earlier, Dartmouth has a system-wide goal of 14 days or less for any specialty, and as we move forward. So
That's laudable. I hope we all make it. I hope that happens.
I do too. I have family members that give me a hard time that it's taking a long time to get in. So
Yeah, I think we all struggle on both ends of our jobs. I get it. Okay, I think those are all of my questions. I appreciate your time and answering them. Thank you.
happy to.
Thank you. Anything from the healthcare advocate?
Yeah, good afternoon. I don't know if folks can hear me. I know we're short on time, so I just wanted to ask one question. I want to thank folks for your focus on bad debt and free care in your presentation and your work with our office on Act 119. I did want to just ask about tangible steps you're going to take to reduce your bad debt to free care ratio. I mean, I think you're aware your ratio is not where you want it to be. And from looking at your audited financials, it looks like you provided financial assistance to fewer people last year than you did in 2022. So I just wanted to ask about the steps you're going to take to realize the budgeted difference. Thanks.
I mean, I don't know an awful lot, bear with me because I'm fairly new here, but I have had several meetings about the Act 119 task force that Mount Ascutney has put together. And it's made up of largely the frontline managers, and they've done quite a bit of work on making sure that the applications are more accessible, that they're out. They really revamped our efforts, and they're meeting on a fairly regular basis to push it out. I think probably we would have to get you more details on specifics that they're doing, but I do know they've taken it very seriously and are working through on it. We can get some sort of a summary of some of the steps they're taking if you would like.
Sure, no, that'd be great. And I know you've been in touch with our office. I just wanted to ask in the hearing context too. Yeah.
Okay.
No, thank you. That's all for me. I think I'll ask right now. Back to you.
Thanks, Sam.
All right. Thank you all for your presentation and your time today. That's all we have. We'll have public comment at the end of the day. You don't need to be here for that if you don't want to be. Thanks for the presentation, and we will go off the record and adjourn until 12:15. Thank you.
Thank you very much, everybody.
you.
We appreciate your time and interest.
Thank
you,
you.
Rob.
Okay, we are off the record.